Our study group will usually last about an hour. I know it's scheduled for 2, but the only time that it will go over like 2 hours if you guys have extra questions outside of what I'm going over. But for the most part, this will be like an hour meeting because we don't want to over exhaust you guys, and people attention only stay focused but for so long, then they get tired. This is at the end of the day. I get it. Okay, so let's talk about first list of diagnoses. So depending on what you're doing, it's going to depend on what you call your first list of diagnoses. If you're coding for a physician, outpatient, ERs, and things like that, they refer to first list of diagnosis as first list of diagnosis. But if you're talking about like a person that works in a hospital, like inpatient, acute, short-term facilities, long-term facilities, psychiatric hospitals, they use the term principal or primary diagnosis. It's basically the same. It's the reason the patient's being seen. It's the reason the patient's having a service performed. It's the reason why a patient may be having a procedure done. That's what your first listed diagnosis is. And so, let me go to the next slide. Hold on. So I have it defined here. First is diagnosis should coincide with the patient's symptoms for why the patient is receiving care when a definitive diagnosis has been established. So for example, patient comes in, they have a sore throat, the physician examines the patient, finds out that the reason for that sore throat after the physician works that patient up is that the patient has tonsillitis. So you would code tonsillitis as your first listed diagnosis or your principal diagnosis or your primary diagnosis because that's what's associated with the symptom for why the patient came in. You're not going to code that symptom of sore throat along with the tonsillitis because it's known to be a part of that. So you don't pull out symptoms that are part of definitive diagnosis. So you would not code the sore throat. Another example would be like abdominal pain, and then the final diagnosis is appendicitis. What's associated or what's causing that abdominal pain is the appendicitis. So you would code appendicitis as your first listed primary or principal diagnosis. Sometimes patients have chronic conditions that are continually being treated when they come in. So, say, for example, a patient comes in with the same scenario. They have sore throat, they have diabetes, they have hypertension, and the final diagnosis is diabetes, hypertension, and tonsillitis associated with the sore throat. First list of diagnosis is why the patient's being seen, which is for that sore throat. So tonsillitis will go first. Because diabetes and hypertension are chronic conditions that are continually being treated and monitored, you will code those if they are being treated with medications. Now, the physician doesn't necessarily have to address that the patient has hypertension other than just putting in the record and you seeing that the patient is on medication for it. Same thing goes for diabetes. As long as there's a medication listed for it, you can code it as a secondary diagnosis. So you would code first the tonsillitis, because that's the reason the patient is being seen, and then the chronic conditions would follow. When a confirmed diagnosis has been established, code the confirmed diagnosis as first listed. Do not code the symptoms as I mentioned before associated with that first listed diagnosis. If the symptoms are always part of that diagnosis, and like I said before, you don't code symptoms when a definitive diagnosis is available. In this example, the patient had a headache. The patient was worked up, found out the reason the patient was having a headache was the type of headache was a migraine. So you wouldn't code the unspecified headache, you would code migraine. When a patient is present with a complaint and confirmed diagnosis, I got something in my way, hold on, has not been established, the first is it may be a symptom. So like if you don't have any additional information and there's no definitive diagnosis, you just have symptoms to code, you would code that headache. So say for example, you never said the patient had a migraine. All you had to code was that headache and you knew nothing more. Because sometimes the doctors don't know more, like especially if it's patients being seen in a physician's office. A lot of times the physician is trying to find out what's wrong with that patient. And so until they know for sure, you may have to code a symptom until they get a definitive diagnosis. The outpatient coding and reporting guidelines are used for physicians, offices, hospital-based outpatient services, or any outpatient settings. When a patient presents for surgery, but the surgery is not carried out due to a contraindication, the first listed diagnosis, the reason for the surgery, and the contraindication code is coded second. So basically, if a patient comes in and they're having a surgery and they're having a hysterectomy because the patient has uterine cancer, but before they actually get a chance to do the procedure, the patient starts having congestive heart failure. I'm just making up something. You would code the cancer first because that's the reason for the procedure, and the congestive heart failure will be coded second. What coded for inpatients is a little different from outpatients because sometimes the physician may document that a patient has a suspected condition. So like, let's go back to tonsillitis in an inpatient setting. If a patient had a sore throat and the doctor final diagnosis is suspected tonsillitis and it's an inpatient, as long as physician did evaluation, worked the patient up for tonsillitis, you can code it as tonsillitis. And this is inpatient only. Outpatient, you cannot do that. You would have to code the symptoms if it's not a definitive diagnosis. Any questions about what I just covered?
So the inpatient, if it's inpatient, you code the after they find out what's wrong with them. Like what the diagnosis he comes up with.
With the inpatient and outpatient, you have to wait until the physician comes up with a final diagnosis. That would be your first listed or your principal diagnosis. The difference between inpatient and outpatient is that inpatient can say or list a diagnosis as a rule out. Rule out tonsillitis, suspected tonsillitis, possible tonsillitis, consistent with tonsillitis, and you can code it as so. But if it's an outpatient, you cannot do that. You have to code the sore throat. You cannot code any rule outs. You cannot code consistent with, probable, suspected, none of that with outpatient, only inpatient. That is the difference.
Thank you.
You're welcome. Any other questions? Okay, so everyone's good with the first listed so far?
Yes.
Okay.
Yeah.
Cool. Here's an example. Chief complaint. A patient comes in with a complaint of chronic skin inflammation, scratching, and erythema. Patient has a history of diabetes and hypertension. First diagnosis is atopic dermatitis. Final diagnosis, not first. It's atopic dermatitis, diabetes, and hypertension. First of the diagnosis is atopic dermatitis because that's what's associated with that scratching and erythema and that skin inflammation. That's the reason why the patient is being seen, not for those chronic conditions. Example number 2, chief complaint, a patient is diagnosed with actinic keratosis of the arms. She arrives at the physician's office for destruction of the lesions. Final diagnosis, actinic keratosis. The reason for the procedure is actinic keratosis, so that's the first listed diagnosis. So again, in this situation, like I mentioned before, the reason for the procedure is going to be your first listed principal or primary diagnosis. Okay, your turn. The patient comes in for an encounter for treatment for GERD, which stands for gastroesophageal reflux disease. Patient also had an insulin prescription for diabetes renewed. What is the first listed diagnosis? I'm asking you guys.
GERD. Would it be GERD?
Oh, we're supposed to type it?
No, you can't type it. I have to type it.
Oh.
GERD.
I need you guys to answer. GERD is the right answer. A patient returns for an office visit for management of diabetes. The patient also has a history of asthma, which is not being treated at this time. What is the first listed diagnosis?
Diabetes.
Everybody agree with diabetes?
Yes.
Yes.
And you guys are correct. A patient comes in to be seen for dysuria. A lab test is ordered for a urinary tract infection. What is the first listed diagnosis? Now, this is an outpatient question. Let's
UTI.
pretend it's an outpatient question.
Dysuria.
Dysuria.
UTI.
And even if it was an inpatient question, it's just being ordered to see, so you wouldn't code UTI. Follow-up office, visit for iron deficient anemia. Patient also complaining of an earache. What is the first listed diagnosis?
Anemia.
The anemia.
I spell that right now. Correct. Okay, so you were right about the fracture. Okay, so we got a
Can we
100.
go-
Woohoo!
go
All right,
back for a
great
minute?
job.
Can we go back for a minute?
Sure. What do you want? Which one?
The one where it was the UTI and the dysuria,
Mm-hmm.
why wouldn't it be UTI?
The patient wasn't diagnosed
Oh,
with it.
because there was a lab test. It wasn't
It
an
was just
actual
a lab
diagnosis.
test. Right.
Gotcha, gotcha.
Right. If it was a definitive diagnosis, like they said the patient actually had the UTI, you would code the UTI, of course. Or
Okay.
even if it was a inpatient, they said rule out UTI, you could code the UTI, but it was not stated.
Okay, thank you.
You're welcome.